Welcome everyone to our Research Connect series. I am Katya Loban, a CDTRP trainee and a postdoctoral fellow at the Research Institute of the McGill University Health Center. I work under the supervision of Dr. Shefali Sandel. I will be facilitating today's webinar. First, I'd like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I encourage you to write your land acknowledgement in the chat box. We would also like to acknowledge Astellas, AstraZeneca, and the CIHR, whose generous support enabled us to host these sessions. Before we dive into the main content, I will pass it over to Erica for some general CDTRP updates.
Thank you, Katya. Today I have one announcement for you all, and it's a save the date for our PFD forum. This year's Patient, Family, and Donor Research Forum will be held virtually on June 13th and 14th. Registration is free and can be done through the link in the chat. Thank you.
Before I introduce the speaker, I have a few housekeeping notes. Today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. If you have a question, comment, you can raise your hand with the raise hand button or type it in the comments section. I'm pleased to introduce our presenter, Dr. Natasha Aleksova. Natasha obtained her medical degree from the University of Western Ontario in 2011. Following this, she pursued internal medicine training at McMaster University and completed her cardiology residency at the University of Ottawa Heart Institute. She returned to Toronto for specialized training, including a 2-year fellowship in advanced heart failure and transplantation at Toronto General Hospital, and an echocardiography fellowship at Mount Sinai Hospital. Her research focuses on assessing outcomes in heart transplant recipients and patients using mechanical circulatory support and evaluating national organ allocation policies in heart transplantation. We're all very excited. I will hand it over to you, Dr. Aleksova.
Thanks so much, Katya. I'll just share my screen to get things started here. So I hope everyone can now see my screen well. I just want to, there we go. I just want to start by saying thank you to the CDTRP for this opportunity. I will be discussing work that has been going on for over 2 years now on the efficacy and safety of COVID-19 vaccination in solid organ transplant recipients. In addition to acknowledging the CDTRP Research Innovation Grant, for which I'm very grateful, I'd also like to thank Dr. Farid Bruton, who's really a colleague and a partner in this work, and Daniel Rayner, our master's student, who provided a lot of the systematic review support for this project. I'll talk a little bit about the rationale for the project, how we assembled the guideline panel, the results of our systematic review and network meta-analysis, which is still ongoing as it is a live research project with continuous updates, as well as our guideline panel recommendations. I think it's important to frame the context of this work. When we started this project, there were about 26,000 Canadians living with a solid organ transplant, and in 2019, the year before the pandemic, 3,000 solid organ transplants had been performed. We knew at this point, and still understand now, that immunocompromised populations are at a greater risk of hospitalization and death if affected with COVID-19 or SARS-CoV-2 as the virus itself is known. And when we started this project, we were seeing a 38% higher absolute risk of death from COVID-19 infection in solid organ transplant recipients compared to the general population. So this would have been early in the pandemic. We know and we still recognize that solid organ transplant recipients do not produce a significant antibody response after standard administration of COVID-19 vaccines. And we have seen 20 to 40% humoral response to the virus after 2 doses of COVID-19 vaccination compared to 100% of participants who were not solid organ transplant recipients from the seminal mRNA clinical trials. And while we understand that there isn't an antibody titer threshold for protective humoral response, the response has been consistently shown to be significantly lower in our solid organ transplant recipients than in the general population. So when we started this project, what we really wanted to understand is how can we, as a healthcare practitioner, help reconcile what to do for my patients, and what kind of advice could I provide? And really, the best way to do this was to start with a systematic review. So we asked the question: can we create a living, meaning continuously updated systematic review or summary of the best available evidence to inform the use of COVID-19 vaccination in solid organ transplant recipients? And then can we take that one step further, and can we actually develop clinical practice guidelines that could be used to help inform our patients as well as our healthcare practitioners in solid organ transplant, in the solid organ transplant community? So what we did, we started with a search for all the trials in the scientific literature that asked the questions we wanted to ask, and I'll get to that in a second. We got an expert panel of patients, partners, thank you to the CDTRP for that, as well as clinicians who were able to basically get all the information from the trial and use that. And the way that information was extracted was by trained volunteers, Daniel Rayner being a lead for that, to basically enter a lot of information into databases that we could then analyze. And that information was used in a manner using statistics to create network meta-analyses where we could provide estimates of benefits and possible harms for each of the treatment options and each of the clinical considerations we were thinking about. And this ultimately allowed us to have our expert panel provide recommendations using the systematic reviews that our systematic review team created to provide recommendations about treatment using this statistical analysis and doing so in a trustworthy, reliable, and comprehensive manner. So this was our panel. It consisted of not only clinicians in the transplant community in Canada, but also in the United States, in the UK, and Spain. And as important as the clinicians and methodologists and transplant infectious diseases colleagues were, the real important members of our panel from the beginning, meaning from the time that we created the questions we wanted to ask to the final recommendations, were our patient partners who are listed here. We had patient partners from Canada, but we also had a patient partner from the UK and Spain as well. So here were the questions we wanted to ask. In solid organ transplant recipients, what is the impact of the number of COVID-19 vaccine doses, such as 3 versus 4 versus 5, etc.? The type of COVID-19 vaccine. When we started this project in 2022 and conceived of it in 2021, this was a big question mark. You know, did it matter whether you had an mRNA vaccine or a viral vector vaccine, etc.? The dose of the vaccine was the third question we wanted to ask. Whether the vaccine was bivalent, incorporating past and current strains of COVID versus non-bivalent, and whether it mattered whether you had the COVID vaccine before or after transplantation. Those were our questions, and then we wanted to determine the outcomes of interest, and we did so in a systematic way by having everyone on our panel, including our patient partners, rate the outcomes that they thought would be most important. And as you can see, mortality, hospitalization, and ICU admission were critical, and the remaining outcomes, including organ rejection, allograft failure, getting the infection itself, COVID-19, and the impact on mental health, quality of life, long COVID symptoms, these were important but not critical outcomes. I'd like to highlight that to this day, there's no systematic review that has evaluated the impact of COVID-19 vaccination strategies on patient-important outcomes in solid organ transplant recipients. So our work was was important in that regard. What I'm going to talk about next is the way in which we attempted to evaluate and understand the answers to our 5 questions, and that is using something called a network meta-analysis. A traditional meta-analysis basically compiles trials that compare one treatment against another, and that's what you see on the left, comparing A to B. And this is important when there are only 2 important treatment options, but it's less helpful when doctors and patients need to consider a range of possibilities. So that's where the network meta-analysis comes in handy, in that it allows you to compare competing treatments for a given medical condition, even when there isn't a trial specifically comparing 2 treatments. So for example, there may not be a trial comparing option A and option C, but if you have a trial comparing option A to B and another trial comparing option B to C, you can indirectly, through network meta-analyses, compare A to C. So that's kind of the broad overview of what a network meta-analysis is. And here's what we did. So what I'm showing you is the work that we completed in July of 2023 and what is currently in the process of being published. However, this project hasn't stopped, and we've just recently reanalyzed data up till March of 2024. So we included randomized controlled trials and observational studies that evaluated different COVID-19 vaccination strategies in solid organ transplant recipients. We conducted our entire search independently and in duplicate, and we ran network meta-analyses when we could, and traditional pairwise meta-analyses when we couldn't. It's important to mention that due to the limitations of observational studies, we only used observational studies where multivariable analyses or propensity matching was conducted, because at the outset, observational data is at high risk of bias and confounding. So we tried to minimize that by using multivariable and analyses and propensity matching. I'll speak to the last point towards the end, but we did use a grade approach for evaluating the certainty in our evidence. And we did that for the network meta-analyses and pairwise meta-analyses as well. So very broadly, what we've found so far is 39 studies, 5 randomized trials of 689 transplant recipients, and 34 observational studies of 114,988 transplant recipients. It's important to remember that none of these patients would have been included in the large randomized controlled trials that were conducted worldwide the year after the pandemic started. So the 5 randomized trials, the people in this trial were on average 58 years of age, about a third were female, and 60% of these trials were conducted in a mixed solid organ transplant population, and 40% were in kidney transplant recipients alone. All of these studies were felt to be overall judged at low risk of bias. For the 34 observational studies, as you can see, we were able to capture a lot more information from 114,000 patients. Mean age of these patients was 54 years, and over 40% were female, and just under half were a mixed cohort of various transplant recipients. About 38% were kidney transplant recipients alone, and 9% of the studies had only liver transplant recipients. Due to the nature of the data, meaning there was a high risk of confounding and a lot of concerns around immortality bias in the way that the data was collected, 86% of these observational studies and their outcomes were adjudicated serious risk of bias. The data did come from all over the world. We didn't limit our search to any language, so we collected data in any way that was published in any language, and 32 countries were represented from North America, South America, Europe, the Middle East, and Asia. The most common country where studies are being published and still to this day are being published is the United States, representing about 44% of the studies that we have included in our systematic review that then informs our guidelines. This just shows the recruitment period of the included studies. So a lot of the studies published around the time of the various various strains of COVID, from the original strain to the Delta strain to the Omicron strain, et cetera. So that sort of reflects the peak publication of different studies over the time frame that we've included. Now I'll talk a little bit about the results. So as I mentioned, we had 5 questions we wanted to ask. The first was, what is the impact on the number of doses when it comes to COVID vaccination in solid organ transplant recipients? I'll first go through the randomized control trial data and then the observational data. What you'll see is often the case is that the randomized control data is fairly slim. Only one of the 5 RCTs evaluated patient-important outcomes. Because of this, we could only look at a pairwise comparison. So COVID infection and organ rejection were evaluated in this study from Hall in 2021, comparing 3 doses to 2 doses of the COVID-19 vaccine and mRNA vaccine. And this study was conducted in Canada at my institution, actually. And they found that 3 versus 2 doses reduced the risk of COVID-19 infection. However, there was a lot of uncertainty about the magnitude of the benefit because the odds ratio crossed unity. And so they also looked at organ rejection and didn't really find a difference between getting 2 doses or getting more doses, like 3 doses of the COVID-19 vaccine. As I mentioned, this was the only RCT evaluating patient-important outcomes. If you're wondering what the other RCTs looked at, well, they looked at seroconversion. And seroconversion is a good surrogate outcome, but for the purposes of conducting a study and getting out results fast. But there were a lot of problems with using this outcome, and we and our patient partners, most importantly, didn't think that that's something that would necessarily matter to them, meaning the relationship between seroconversion and COVID-19 protection against COVID-19 infection is controversial. And second of all, it's not an outcome that would matter to the patients in our from our patient partner group. So what did we have? We had a lot more observational data. There were 30 observational studies that looked at the number of doses, and we were able to conduct a network meta-analysis for COVID-19 infection, hospitalization from COVID-19, and mortality due to COVID-19 infection. And what we found was a very clear dose-response relationship. Basically, as the number of COVID-19 vaccines increased from 1 dose to 2 doses to 3 doses to 4 doses, there was a reduced risk of COVID-19 infection with a significant odds of not getting COVID infection if you'd received 4 doses of the vaccine compared to 3, compared to 2, compared to 1. This was very important finding, and the only concern around this was that it actually didn't translate into other patient-important outcomes. So while COVID-19 vaccination was important in terms of the number of doses to reduce your risk or your odds of getting the infection, when it came to hospitalization, as you can see on the left in this forest plot, as you get more COVID-19 vaccine doses, your risk of ending up in hospital does decrease. But then when we added the data for 4 doses versus 3 doses, there didn't seem to be a difference. And similarly, while there seemed to be, when we were starting this project, as you increase the number of doses, a clear signal that the risk of dying from COVID was less, when you add on data from the most recent observational studies looking at 4 doses versus 3 doses, the magnitude of benefit included both benefit and no benefit to more doses. So we didn't actually find a dose-response relationship as we continue to add data to our systematic review, and I'll get to why we think this is at the end. We then wanted to look at the type of vaccine. So in addition to number of doses, we wanted to ask, well, does it matter what type of vaccine you get? So 3 randomized controlled trials actually compared the mRNA vaccine to a viral vector vaccine made by Johnson & Johnson. And as you can see, these randomized controlled trials had very few events. They were small studies. And in looking at COVID-19 vaccinations, when they compared mRNA vaccines to non-mRNA vaccines, overall, the odds ratio includes both benefit and no benefit with an mRNA vaccine, suggesting that overall mRNA vaccines may make little to no difference on mortality, as well as COVID-19 infection, ICU admission or rejection compared to the viral vector vaccine by Johnson & Johnson. And because this is all observational data, we have low certainty in the evidence. In terms of different kinds of mRNA vaccines, only one randomized trial compared the mRNA 1273 or what's called Moderna, the Moderna vaccine, to the BNT vaccine by Pfizer. And when you look here at COVID-19 infection, there was really no difference between one type versus another. And similarly, when you compared the 2 vaccines for dying from COVID, there was no difference. But I caution you again that this was a small randomized trial. So then we turn to our observational data because we had so many more patients and so many more patient events to look through. And 5 studies actually evaluated the type of vaccine on patient-important outcomes. And they assessed the Pfizer, Moderna, and the AstraZeneca vaccines. And the most important thing to highlight here is that when it came to the type of vaccine, there was really very low certainty in the evidence for all the comparisons. And that's because the point estimate included both benefit and no benefit with the different comparators. And the only one that was not very low certainty, but just low certainty evidence was that the Moderna vaccine may reduce mortality from COVID-19 compared to the Pfizer vaccine. However, this was based on just one study published now in 2022, suggesting that if you were to translate their odds ratio to practical terms, that you would have 70 fewer per 1,000 solid organ transplant recipients die of COVID-19 if they received the Moderna vaccine compared to Pfizer, but that true estimate could be anywhere from 102 fewer to 204 fewer. So because this data was observational and marred by confounding, we felt that this was low certainty evidence, and that would be the case, as I said, when I started, for most observational data. What about the dose of vaccines? So we've talked about the number of vaccines and the type of vaccine. When we looked at whether it mattered whether you received a standard dose versus a double dose in one injection, there was only one randomized controlled trial that evaluated this. And they looked at COVID-19 infection and organ rejection. The rest of the outcomes were, as I mentioned, surrogates based on laboratory values or things like seroconversion. So as you can see here, there was no difference when it came to COVID-19 infection between receiving a double dose or a single dose of the COVID-19 vaccine studied here. And similarly, no difference in terms of organ rejection risk. For dose of vaccine comparing single versus double, there was no observational data that was that used multivariable analyses or propensity matching or some sort of statistical method to control for confounding. So we had nothing that we could compare to that would be even remotely trustworthy. In terms of bivalent versus non-bivalent, meaning bivalent is the kind of vaccine where they incorporate the current strain and previous strains versus non-bivalent vaccines that are just updated, there was actually no randomized or observational data for comparison. And when we tried to see about indirect evidence from randomized trials, there was nothing we could incorporate. And then lastly, the fifth question we will ask as a guideline panel related to vaccination before or after transplant. So this is indirect evidence because it's an indirect outcome. The only thing that we could find that was a comparison that is trustworthy was a study in kidney transplant recipients where they compared 2 doses of the Pfizer vaccine pre-transplant to 2 doses of the Pfizer vaccine post-transplant. But the outcome of interest was seroconversion, or seeing if you form antibodies to the COVID-19 antigens. They measured seroconversion 1 month after the second dose, and then, they measured pre-transplant seroconversion 1 month after transplant, and then in the post-transplant group, they measured seroconversion 1 month after the second dose. And what they found was that if you receive the 2 doses of Pfizer prior to transplant, you were far more likely to seroconvert or make antibodies compared to the group that got the vaccine only after transplant. So what that, in absolute terms, what that means is that there were 499 more patients who seroconverted when they received the COVID-19 vaccine from Pfizer after transplant compared to before. And this was low certainty evidence because it's indirect, and there's serious risk of bias because this was observational data. And when you take into consideration all of this information, the bottom line, or the plain language summary for this finding, is that vaccination pre-transplant may increase seroconversion post-transplant compared to vaccination post-transplant, but this is, as I mentioned, low certainty evidence. So I just very quickly presented our, pretty much a 1.5 years of work to create the findings of our systematic reviews. And then from our systematic reviews, which are currently submitted for publication and hopefully will be published soon, we then moved on to guideline recommendations. And the way that our guideline recommendations worked was we met first to establish what were the questions we were going to ask. We then met again as a group, and meeting across international timelines created its own set of challenges, but we met as a second time as a group to review the body of evidence as demonstrated from our systematic reviews and meta-analyses. And then we met a third time to vote on our recommendations after reviewing the evidence again. And we use GRADE, and GRADE consists of 2 parts. You grade the strength of the evidence, and as you saw from a lot of what I showed you, the strength of the evidence is mostly low. And the second part, which is why you have a guideline panel, involves grading the strength of the recommendation. So the strength of the recommendation can be either strong or weak, for or against a specific intervention. So the 4 options basically mean that if you have a strong recommendation, what you're basically saying is that almost all informed patients would choose to have the intervention. If you have a weak recommendation in for or a weak recommendation against, that means you have to discuss with each patient. And then strong against means that almost all informed patients would choose not to have the intervention. And that was not the case here, but I'm just telling you that there are 4 options when it comes to guideline development. So our first recommendation was for the number of doses, and what we voted on and had consensus for our group was that in solid organ transplant recipients who are at risk for COVID-19 infection, we recommend 4 providing additional doses of the COVID-19 vaccine. And this is a strong recommendation, accepting the fact that there's low certainty evidence. When it came to the type of vaccine, our panel decided the following. in solid organ transplant recipients who are at risk for COVID-19 infection, we suggest, so it's a weak recommendation for taking any immediately available type of vaccine as opposed to selectively choosing the type. This was a weak recommendation with low certainty evidence, and we discussed this as a panel quite extensively, and it created a lot of discussion. And ultimately, what we decided to say is that any available WHO-approved vaccine, for our patient partners, this information was probably the most important, as there's been a lot of, at least at our center, a lot of question and discussion around the type of vaccine to choose. And as you can see from the available evidence, there really was no significant difference for the majority of the outcomes that we looked at, and mostly based on observational data, suggesting one type of vaccine is better than another. And as a result of that, we felt comfortable saying that any immediately available type of vaccine is the one to accept, as opposed to selectively choosing or waiting for a specific vaccine to become available. And this recommendation is weak because there was some discussion around whether the mRNA vaccines, for example, there might be some signal of benefit, but nobody felt comfortable saying that this is that we should recommend one type of vaccine over another, because the available evidence didn't support that type of a recommendation. Our third recommendation was regarding the dose of the vaccine. And so because there was very little evidence to support any benefit in solid organ transplant recipients who are at risk for COVID-19 infection, we suggested as a panel against providing a double dose of a selected vaccine as compared to standard dosing. There was really insufficient evidence to make a recommendation for bivalent vaccines, so we actually did not make one because we didn't think it would be helpful to just make a statement without having some evidence to back it up. The last recommendation is regarding timing of the vaccine. So what we recommend is as follows: in patients requiring and anticipating solid organ transplantation, we suggest 4, meaning it's a weak recommendation, but we suggest 4 vaccinating before transplant as compared to after transplant. And this is based on low, or some might argue very low certainty evidence. However, the reason we felt this was the case was, and I didn't show it to you here, was based on some indirect evidence from non-immunocompromised patients, in addition to the kidney transplant study that I showed. That's what framed our decision making for this recommendation, and all of this was recorded and it's part of the record, so that it is fully transparent in terms of anyone who wants to see how we came to the conclusions that we did. There was a lot of important limitations to this work, and some of it relates to the data available. So whenever you go to conduct a systematic review, a limitation may be the data that is available, but that's not really the fault of the systematic reviewers or the guideline panel. That's just the reality of the scientific landscape. So what we realized is that, there really is a paucity of randomized controlled trials in solid organ transplant patients powered to look at anything more than immunogenicity outcomes. I think that after everything is said and done, the way forward when it comes to hopefully a long time away, but the truth about a pandemic is that it can happen again and will happen again. But understanding the way in which we intervene and use vaccination in our solid organ transplant patients, I think has to be more at the forefront rather than an afterthought, limited in number and limited in scope. We did leverage observational studies where we could, because they had large sample sizes. We were able to look at over 100,000 patients and their outcomes. But while this is real world data, and that's fantastic, this type of data is very prone to selection bias, and it's very prone to confounding bias, because you're not really randomizing or controlling for other covariates in a systematic way. We only identified evidence for 4 vaccines. So some of our patient partners who are not North American brought this up and said, you know, we can really only speak to the 4 vaccines that we had data to analyze. We didn't have data for other World Health Organization approved vaccines, but we did have data for the 4 most commonly used vaccines worldwide: the mRNA vaccines, the AstraZeneca and the J&J Johnson & Johnson vaccine, the viral vector vaccine. And lastly, there was a limitation of the time period in which the studies took place. So as we added more data, as we saw in our forest plot, once we got to 4 doses, and I suspect we may see this with 5 doses, while there is a clear dose-response relationship to more doses means less COVID-19 infection, what we stopped seeing was more doses equals less COVID-19 death and less COVID-19 hospitalization. And that's most likely related to the fact that this process wasn't static. There was substantially different baseline infection rates at the beginning of the COVID-19 pandemic, and far different event rates when it came to hospitalization and mortality compared to the post-vaccination era. So that's just a reflection of basically science and progress, and we see that in our results. What were the lessons we learned from this project, which is still in progress? Well, it's actually very difficult to develop a rapid development of a guideline when a medical problem is continuously changing. It's also challenging when you want to incorporate different parts of the world to do so in a timely fashion. So we're just now publishing our work, hopefully in the coming weeks. I think it's important to continue, and what I think we did well was involve our patient partners in this work, and they were voting members of our guideline panel. But in future studies, particularly randomized trials in this area of medicine, I think having patient partners as part of the process will probably bring to the forefront more patient-important outcomes, such as what was raised in our cohort. So with about 20 minutes to spare, I'll end it there. The next steps for this project really are continuing the work. We are setting up basically a magic app that will allow us to keep dumping data into our findings, so that, you know, as things evolve, and believe it or not, there's still a lot of COVID-19 related research that's being published. In my area of practice, heart transplantation, there have been several large studies that have been recently just added to the scientific community's understanding of 5 and 6 doses, and what does that mean, and does it impact things like organ rejection and other outcomes such as long COVID symptoms. So we still have more work to do, and we're in the process of doing it. I can't thank the CDTRP Research Innovation Grant enough for funding this work, and I can't thank the members of our guideline panel and Dr. Farid Burton and Danielle Rayner, who did a lot of the background work to put this project together. I'm happy to take any questions, and I'll just maybe stop sharing my screen so I can see if there are any.
Great, thank you for this excellent presentation. Yes, if you feel free to post questions in the chat box, or just unmute yourself and ask them. Yes, please, Patricia.
I had my actual hand up and my virtual hand up as well. Thank you very much for the great presentation, Natasha. It was, first, I want to congratulate you on focusing on patient-important outcomes. I think it's really interesting the number of studies that were not helpful to your efforts because they did not include any of those. What an enormous investment of of time and money, frankly, in all of those studies that aren't necessarily focusing on the things that really matter to patients. So I found that really striking. My question was about communicating the results to the people who can take action, namely, transplant programs, patients and families directly. How had you envisioned your guidelines sort of making it into action?
Yeah, that's a great question, and I think what we initially envisioned was going to be faster, and then reality was that it took longer. So when we first started, we thought we would be ready to have our guidelines available to disseminate last October, but that just didn't happen for many reasons. So the first, I think, the traditional way in which we disseminate information is through publication, and so that's what we're in the process of doing. But I don't think that's enough, because while large transplant journals are looked at by healthcare professionals, we don't think that is going to actually get information to our patients, particularly as the next COVID-19 season, which is I think where we're heading, comes in the fall. So one thing that we're doing, we're going to start by using our own center's platform. So the Edgemera Transplant Center at Toronto General Hospital has a website. So we're going to put it on there and use social media to provide updates for our patients so that they can see this. We're also going to, two of our patient partners are they themselves very large, they're advocates in their own respective transplant communities. One is with heart, one is with lung. And so they've sought to share this information with their respective, one is a Facebook group, and one is just a sort of a patient partner group called Heartling. To share this nationally is, I think, where we actually have some connection, but not enough, to be honest. We have connection to the other programs in Ontario, and specifically London. When they heard about our presentation, the transplant group there wanted us to provide them with all our documents once published. But the rest of Canada, I think we need to work on that. We have one of our panel members from Alberta. One of the ideal situation was to have panel members from across the whole country, but believe it or not, assembling our panel took a long time to get people who had the time. Everyone's interested. It's never about lack of interest. It's more just about time. People having the time to meet, to review data, to meet again, to vote. That's where we struggled getting that kind of a commitment. But it's a great question that is in the process. We're starting provincially by using our transplant website, and then I think we need to work on disseminating this information to the rest of the country in a way that's accessible to the people that matter most, which is our patient partners, and why we did this work in the first place.
Thank you. Sean?
Yeah, fantastic work, Natasha. This is very good. And I'm so happy to see some of the authors on there were patient partners right from the outset. So that's fantastic. And Rank, I see you online, and others that were part of that. So very good to see. My question, and this is a little bit timely because I literally had my COVID shot number 9 last night. That's why I'm wearing 2 jackets, because I've been taking it on and off throughout the day. So I'm assuming that means I had a minor reaction. But what do you see as the implications going forward for shots 8, 9, 10, 11, 12 for some of us, because I feel like at this point in time, and this I'm not outing anybody, but I had to lead the conversation this time about getting this shot because it was being released by the Alberta government, and I'm emailing my program like, so should I be getting it? I'm up to 6 months now. And there was no official guidance yet coming out. So I was now leading that discussion. So, what are we to do, when the official guidance is coming slower and slower? I don't know what the experience of Charles and Rank and others is there, but that's been my own personal one here.
Sean, that's fantastic, because I think that's one of the challenges with creating a guideline where you're going to at the outset say, I'm going to use the available evidence to guide my decision making. Is you're limited by what's out there, and there's a lag. And so your question is great. What I can tell you is that getting vaccinated, each subsequent vaccine does prevent you from getting the COVID-19 virus and infection. But your point about, well, what do I do 8, 9, 10, and how far apart, that's gonna, that's part of our subsequent, that's why we're keeping this going, is to try to see if we can go back and or not go back, but look at our most recent set of data to see, can we answer that question? And that question is, what's the interval with which I should be getting vaccinated? Is it actually seasonal, like the flu shot, or is it on a 6-month basis, like what is currently being recommended, but based on actually no evidence other than the thought that your titers of antibody go down over a 6-month period of time. So that's the next phase. That kind of data was not available for the first 3 years of the pandemic, but right now it matters, and that's the challenge. With we could make a recommendation as a group based on our opinion, but I don't know that that's the route we wanted to take. And that's how a lot of, if you look online, some of the large organizations in the US have made some recommendations, and they've done it mostly based on maybe a couple of studies and just saying, okay, this sounds right. But the honesty of it is, we don't know what the impact of the 8th and 9th and 10th dose is. We have good evidence to suggest that each subsequent dose reduces your risk of infection, but what does that mean for you in terms of ending up in hospital and dying of this infection? There seems to not be as much clarity there. And understanding that is, I think, the next part of this project, and that's why we're continuing it. And that's the intent, is to kind of keep this going, because it's going to be relevant, at least relevant for the foreseeable future. And the hope is that it spurs interest in the kind of research that might answer your question a bit better, right? Which is,
yeah,
you're the one who's kind of telling your province and telling your transplant community about what to do, but really we should have a little bit more evidence to back that up.
Yeah.
Well,
and
just to mirror what from one of your early slides, that literally, I was part of the UHN study actually as a patient.
Oh,
Through Edmonton participated, so that's how I was involved. But that was the second dose was a 0 response, and the third dose was the actual response, which was kind of mirrored what you had there for when it actually kicked in. So not that you were took a deep breath and finally I'm fully covered, but you at least had something, right?
Mm-hmm.
Right.
And Sean also added in the chat box, there's also an AACI lag at times. And before I take another question, I'd like to acknowledge that Donna sent a message saying, nice to see a study we recipients can point to for the scientific facts on COVID-19 immunizations. Thank you, Donna. Rink, I'm sorry, I don't know. I'm sorry, I'm probably butchering your name. Please.
Rank and I know each other well. Hey, Rank, how are you?
Oh, I think there may be
frozen.
a little bit of a connection issue.
Yeah.
Yes.
Maybe can I sneak in another question while Rink is unless
Yeah,
he's...
sorry, I've lost the screen. Can you hear me or not?
We can hear you, yes.
Oh, okay, yeah. No, it was just, yeah, I just wanted to share also that what I really appreciated about the work that Natasha did and the team is we had real conversations about real facts that in a lot of cases weren't there. And I think that is just a big difference between someone that's saying, hey, I'll make a decision for you. I think this is right. It's about sort of sharing the truth. And so I was really impressed with the process and the way we actually did it. Now, it does take time, right? But I think it's important to take that time and to keep looking, because it's too easy to be flippant in a lot of these things. And so looking at the real data that's out there and how valid we thought it was, I really thought it was a fascinating set of discussions from all our various perspectives. So I thought it was very, very good. Yeah, I wish we would do that for all research. But so that was it. I just wanted to say thanks. I really appreciated being part of that.
Thank you. And Patricia, we'll go back to you.
Question. Thank you. The other thing that I found really striking, and maybe by striking I mean disturbing, is what you showed about the lack of a dose response with mortality when you're getting to the fourth dose, and you alluded to the level of baseline virus circulating that may be responsible for that. So infections become much more likely. And so that fourth dose, where we seem to be almost losing ground if you're looking at overall mortality as an outcome. If that's true, what does that mean for the recommendations now that we have no public health guidance in place regarding masks and other social and non-pharmaceutical measures to prevent infections, in line with vaccination programs and sort of public behavior and public policy?
Yeah, that's a great question. I think, we were hoping when we did this first analysis with COVID-19 vaccination, where you clearly see as you get more doses, you're less likely to get infected. I think the reason for this, and I'm happy to share with anyone who wants to see it, part of the reason that we see when you look at hospitalization or death, what happens is that, you move as you increase the number of doses up to 4. Now we have data on 5 and 6. We just have to add it to this. The data on 7 and 8 isn't even in the works because nobody's published it yet. But once you get to 4 doses, you see that while the odds favors COVID-19 vaccine, you have a very wide confidence interval. And part of the reason is that fewer people are dying of COVID, including our transplantation. So I think when I'm presenting this data, the figure is one thing, but the details or the numbers behind it is that that COVID-19 vaccination reduces your risk of getting the infection. As you increase the number of doses, whether you get vaccinated or not may not necessarily reduce your risk of dying, but that applies to everybody, because we know from large registry and observational data that as you move further, and we looked at this at UHN too, as you move further and further from the alpha strain, across all organ groups, the risk of dying from COVID is less in 2024 than it was in 2020. So that's what Patricia, that's what this partially reflects. It reflects the fact that the attack rate, or the rate at which this virus kills people, is fewer, and it's not like another outcome that would be static, like the risk of dying of a heart attack after a heart transplant. It's pretty much going to be the same. Whereas with this virus, it's changed and mutated such that fewer people are dying from it. So that's partially what you're seeing here. We have to report it as there is, while there is possibly fewer deaths with 4 doses versus 3 doses, that the confidence interval is wide. There aren't that many of them. And there's a possibility that it makes no difference, because as you can see, the odds favors both more and not more vaccination. What does that mean for public policy? I don't know that it changes necessarily what public policy would look like, because we still know that vaccination makes a difference in reducing the risk of infection. What does that mean on an individual patient basis? I think that there is some discussion that is warranted. And I think the other thing that's important is we're going to add to this. So I think now that we've gotten past the point of getting a panel together and putting all of our data into basically a database, the part of just adding to it will help answer your question a bit more, because as we move further and further away from 2020 and we start to see a pattern of infection rates, maybe something not quite, because I'm not an infectious diseases specialist, but something more like what you see with influenza in our solid organ transplant community, we'll have a better understanding of not only the impact of vaccination on infection rates, which we see is less as you get more vaccinated, but having a better understanding of like what is happening to things like hospitalization. Another thing that was hypothesized as being part of the reason why once you get to 4 doses, it doesn't seem to make a difference whether you end up in hospital or not, is because we know that in a lot of centers in the US and Canada, we started to use outpatient medications, antiretrovirals like remdesivir. So we hypothesize that that might also explain why you're not seeing that same reduction in risk of hospitalization. But I think this just speaks to the fact that we're just, you know, honestly, we're getting started. Every month I get about 300-400 new citations to screen. So there's more to understand about the effect of COVID-19 vaccination, particularly on long COVID. So that's something our patient partners brought up. It's not something I thought of, they did. And that's something I think we're going to be able to understand a little better as more data comes out in the next year or so.
Mm-hmm. And Mr. Fall also mentioned the concept of hybrid immunity and mentioned new VOC impact and waning immunity. So I see that I see that our time is almost up. Thank you for the questions and the comments throughout today's presentation. Dr. Aleksova, on behalf of the CDTRP, thank you again for presenting. If anyone has additional questions, comments, or suggestions, or suggested topics and speakers, please contact Erica Croft from the CDTRP. And I want to mention that all participants will receive an email asking them to fill out a survey, and we would appreciate it if you could take 3 minutes to complete it. Thanks, everyone, and enjoy the rest of the day.
Thank you again.
Thank you.